Welcome back to the Anja Health podcast. Today, I'm super excited to have Christian Toscano, who I also love your name. It's very movie like. But yeah, Christian is a licensed midwife, a clinical herbalist, and also a craniosacral therapist. And today, we're going to chat about insemination, menstrual health, hormonal health. So yeah, I'm super excited to have you here because those are all new topics for our podcast. But yeah, I'd love to get a brief background on sort of you and how you got here, and especially how you got interested in just the more kind of herbal realm of health.
Well, thanks for having me. So, my background is in herbalism. And as I was kind of going about that journey, I was working as a doula in the hospitals, and I really wasn't liking what I was seeing. And I was feeling like there had to be another way. I didn't understand why birth was so hyper controlled and
Mm,
over medicalized. And when it didn't need to be, there's definitely births that need a lot of intervention, and we're grateful for that intervention. But when I was in that system, I felt like, we're missing a piece, and which is these are transformative life experiences that are inherently sacred. And
hmm
why are we not coming to it with some intelligence and understanding that the body is designed well and knows what to do? So I went on after herbal school to become a licensed midwife, and I have a private practice now on the East Side in Los Angeles, and I specialize in home birth.
Okay, awesome. I'm curious what inspired you to be a doula.
It was at the time when I was 28, and a couple friends had started having kids, and I realized that I didn't have a good relationship to birth. I kind of just had what society had showed us, which was it's to be feared and just something to just get through. And
hmm
I didn't understand why, we're mammals. Like, why all of a sudden do we need all this help having babies when we've evolved over time having
Yeah.
babies?
Yeah, that's interesting. So, do you happen to have kids of your own?
We don't, but we're trying now, actually.
Oh, okay,
Yeah.
awesome. Cool. Well, yeah, as you know, we do cord blood banking at Anja Health, so I'm curious what your thoughts are as someone in the birth space, and also if you would do it for your children.
Yeah. So we don't have a one size fits all approach. That's really midwifery care. We tailor everything to the individual in front of us and what is their clinical picture. So we do operate under ACOG guidelines. So we do say, ACOG doesn't they don't recommend for or against it, but then we look at the individual's family makeup. And so it's like, do you have a history of genetic, metabolic conditions where this could be of use for you potentially down the line?
Mhm. Okay, awesome. So, do you think you might consider it for your kids? And also, I'm curious what your thoughts are in relation to that delayed cord clamping.
Yeah. Delayed cord clamping is definitely a hot topic right now. I personally wouldn't do it for my kids because I don't have any known genetic conditions that I would be concerned for. And that is the interesting thing now. So we have like this explosive realm of genetic screening. So people will come in before they've conceived, and they will have
Mhm.
these complete profiles on both themselves and their partner or their donor. And then we can really make an informed decision around, what are some things maybe you might want to consider.
Right. So, would you do delayed cord clamping for your kids?
Well, absolutely. Delayed cord clamping is just part of midwifery care.
Yeah.
The way that we approach physiologic birth, meaning unmedicated, is when a baby's delivered, they go straight on top of the birthing person, the mother, and we're doing the assessments on them, and we're not cutting the cord. So,
Mhm.
we're that is essentially the baby's backup oxygen supply. They're getting their stem cells. They're getting up to a third of their whole blood volume. And so we typically don't cut it unless for some reason we needed to help facilitate resuscitation for the baby if we weren't able to do that on the mom. But typically we don't cut it for up to an hour,
Mm.
which is very different than what the hospital calls delayed cord clamping, which is about 20 to 30 seconds,
Mhm.
which to me is still immediate clamping. And that really varies from provider, but a lot of that is because in the hospital, it's set up more like an assembly line. And in order for them to break up the room and let the team disperse and attend another patient, they have to kind of complete their duties with that one in front of them. So the benefits of midwifery care is that we're really tailoring the whole experience to the individuals in front of us. Fortunately, we don't have other people to go run to, so we can make that really one-on-one, like concierge care.
Right. Okay, awesome. What makes you say that it's a hot topic right now? Delayed cord clamping specifically.
Yeah, I feel like because people are reading about this and saying we want this for our kid. We know we're hearing about stem cells. We're hearing about the importance of, delayed cord clamping.
Mhm.
And so then they ask their provider, or they request it at the birth. And what people don't realize is that the time in which it is done. So here we are trying to get educated as consumers. I want to advocate for my baby to have as much of their intended nutrients and blood and stem cells in them. And also, it's a backup oxygen supply. So, if we have a baby that's transitioning or needs a little help transitioning to being an air breather, we have them getting oxygen through that cord.
Mhm.
In the hospital, it's not defined what exactly delayed cord clamping is in terms of time. So, the midwifery model is to wait until there's absolutely no pulse happening, meaning, the baby has gotten all of the blood, all of the stem cells inside of them. And the cord goes to looking like a fat, robust, pulsating cord to like a thin piece of linguine.
Yeah. Okay, awesome. So what do you view as sort of the pros and cons for cord blood banking?
I'd say, we look at the individual. So, like, if they do carry thalassemia, if they have sickle cell, if they are at higher risk for certain cancers or tumors, leukemia, things like that. I do have some questions for you actually
Yeah.
regarding that because my understanding is that with sickle cell and thalassemia specifically, if that's coming from the individual, that their stem cells potentially have those diseases to them and that they
Mhm.
might not be useful.
Yeah, well, so it kind of depends on the disease. There's certain genetic conditions for sure that is the case, but sometimes it's not the case. Yeah, it really just depends. And also there are certain cases where people have used like a siblings, for instance, when the sibling does not have sickle cell anemia. So yeah, it's really just dependent on the case. Yeah, for that reason, actually, we have a partnership with Billion to One, which is a genetic testing company, and essentially, they'll cover the first year of cord blood banking if the baby tests for some kind of disease that could be potentially treated with their own stem cells. So there are cases in which they can be treated with their own stem cells, but yeah, like you mentioned, sometimes it is the case that they can't.
Hmm. And the rate of the ability to use the sibling cells also is around like
Yeah.
25% if it is a.
It's a 75% match. So it just kind of depends on the physician's oversight and usability. Like sometimes people use stem cells that are an even lesser match. But yes, full siblings are a 75% match.
Hmm, cool.
Yeah. Do you have any other questions on cord blood banking?
Yeah, so I was wondering if there were studies about because we have definitely cord blood banked for clients, and I'm wondering if there's studies are on having them being obtained right after birth, meaning a minute to 30 seconds after the baby's born to an hour, because like I said, the midwifery model is to really wait until that cord is done pulsing,
Yeah.
and then we cut the cord.
Right. Yeah, yeah. So, with us, we recommend banking after up to 2 minutes of delayed cord clamping. So yeah, it generally follows a more hospital birth type model. But we have worked with midwives as well who will do the 2 minutes and then bank the rest. But if they do want to delay beyond 2 minutes, then they can choose to just bank their cord tissue and placenta with us. So that's where we collect the cord itself. So it doesn't necessarily have to have the blood inside, and then the placenta separately. So yeah, with us, the parents can choose to do cord blood, cord tissue, or also the placenta, and they can choose one, two, or three of any of them.
And what if there's like an abnormal placenta or there's an infection
Yeah.
or if there's antibiotics or something received in labor, would you still bank the placenta?
Yeah, actually, if there's an infection, we can treat the placenta ourselves with antibiotics so that it's not stored with an infection. So antibiotics is fine if they do that beforehand. But yeah, we generally will take it in. But yeah, it just depends on the exact case.
Cool. Oh yeah, the length of time cord blood can be stored.
Yeah.
What is the my understanding is the research shows it's about 15 years, but other I've seen other banking websites talking about that they talk about like the length of indefinitely or the length of the individual
Yeah.
or yeah. Can
Yeah,
you
well,
speak
so
to that?
we store for 20 years or we can store for a lifetime. So that's kind of our pricing options and the way our prices are broken down. But yeah, thus far there isn't evidence really that the stem cells lose quality based on having more years of being stored and cryopreserved. So yeah, I think the longest stored stem cells are from like around the 80s, like the late 80s and early 90s is really when cord blood banking started to come into practice. So we've only really seen it observed in max 30 years, but there are stem cells that have been stored that long and are still deemed viable. So yeah, for that reason we offer the lifetime plan.
Do you know why then they say the 15 or 20-year like how does that differ between the 15 and then the lifetime?
Yeah, well, I guess I don't know. Do you know the source of the 15 years? That exact, or is it just something you've heard?
I think it was through the American Academy of Pediatrics.
Oh, okay. Hmm. I haven't seen it, but I'll look into it. Yeah, because generally, like, I've looked into studies around, yeah, just viability over time, and I think they've seen, like, with embryos, for instance, or eggs and sperm that's been frozen, cryopreservation doesn't necessarily deteriorate the viability of it, so it's kind of assumed that for stem cells, it could be the same case, but yeah, but I'll look into the APA study.
Cool. Can you speak to how a family history of malignancy or genetic conditions, how that can benefit the family as a whole? Because I do know, like with
Mhm.
we've talked about this with twins that are carrying. If one is at a higher risk for carrying congenital disease, then that might be a good option for them to consider the families.
Yeah. Yeah, definitely. Yeah, well, so like I mentioned, siblings are 75% match and parents are 50% match. So I think the thought is that if you save it for yourself, then it can definitely potentially be used for other family members and kind of beyond the sort of nuclear family that I mentioned of siblings and parents. I feel like yeah, it could be any number of like percent match. Yeah, it just depends on who it's for, but generally there's one study that I reference pretty often on our site, but there's a graph that basically shows months or probability of survival and months after receiving a stem cell treatment on the y and x axis, and essentially it shows those that were related to a stem cell donor and those that were not, and the chances of survival overall are on average generally higher for those that are related to the donor. So I think there's just less of a chance of getting host versus graft disease, aka like a transplant rejection, if you're related to the donor. So yeah, like the reason I started Anja Health is because my younger brother had cerebral palsy and needed cord blood stem cells. So it wasn't even necessarily a genetic condition, but my family just always wished that we had it somewhere in our family because the potential for host versus graft disease could have potentially been like fatal even for my brother. So yeah, so I think the having accessibility to a related donor for stem cells is something that is just really crucial to the process.
Hmm, fascinating.
Yeah. I love that you prepared some because a lot of people
Thanks.
don't have too many.
Well, it is because it's a hot topic, and we do
Yeah.
get asked by our patients about this, and
Yeah.
it seems to be like it's hard when we have these governing bodies that are like
Mhm.
we're not for or against it, or we're actually we see no benefit to ensuring genetic preservation or whatever, and then there's like the companies that are doing it, seem very convincing, and so then we go, well, like, how do we advise
Right.
our clients?
Yeah. Yeah, I think it's just kind of dependent on like generally I see parents that just err on the side of caution, like tend to do cord blood banking. Also, obviously, we're unfortunately not covered by insurance. So I think those that just have more disposable income and are able to budget for something like this, it's just kind of like a means of being able to take advantage of a resource that's just normally thrown away. Um, yeah. I feel like another hot topic on social media is umbilical cords and placentas being sold. If you have any thoughts on that. So
Yeah, they've
whenever
always been revered. I mean, like even in, turn of the century France, like placenta tissue was used in cosmetics and,
Mhm.
for that very reason of stem cells.
Yeah. Yeah, yeah, so whenever I talk about, on social media, like, "Oh, yeah, you don't want it to get thrown away, like, you could potentially just save it," then I get a lot of comments that are like, "They don't even throw it away, they sell it."
I don't know about that. We, I believe in the hospital they're incinerated. It's treated as medical
Yeah.
waste, which does seem sacrilegious, because it does have all of this potential
Mhm.
goodness to it. But our clients, when we leave them with the baby and the placenta, so
Yeah.
they can. Some will encapsulate, some will dispose of it, some will plant it in their yard and plant a
Right.
tree on it. Yeah, some will, eat it. So
Yeah.
it varies.
Do you have thoughts on consuming a placenta or placenta encapsulation in general?
Yeah, I do. All of these things are so interesting where we have these like not that it makes it seem like I'm just like this traditionalist, but I really do look at evolution. I look at like, well, how have things been done or what do mammals do, right? Like mammals don't lay on their back. Mammals don't birth when they birth. They don't invite in all these strangers. They don't go under bright lights. So to me, then I also think about the placenta and mammals typically do eat their placentas, but human mammals haven't really.
Mhm.
But there is some interesting studies that are coming out that shows that it can be supportive for those with postpartum mood disorders.
Mm.
Um, but I look at things holistically too. So I'm like, well, why do we have the prevalence of postpartum mood disorders? Is it because partners are expected to go back to work within a short amount of time because we don't have paid maternity leave because we
Yeah.
live in nuclear families where people are under supported and like don't have the adequate support they need and rest for their body to heal from what they just went through, whether
Mhm.
it be a surgical birth or a vaginal birth. Like your body needs time to recuperate. And then if you're feeding your baby from your body. Um, so yeah, it's like, is it, a cure all? No. But for people who are inclined to, I'm like, go for it. But we advise against it if you've had like antibiotics in labor
Mhm.
or an infection or needed any kind of augmentation in the labor, like Pitocin or something like that.
Right. Okay. I'm curious what attracted you to home birth specifically, especially since it seems like you previously worked in hospital births as a doula.
Well, I found hospital births to be really traumatizing. I really didn't see people enjoying their experience. I saw people being coerced into inductions and births that they didn't want to have and part of that, to be fair, is I wasn't a medical provider then, so I didn't really know was that medically necessary? Like
Mhm.
I didn't have the full picture, but I did know in myself like I need to then learn how to assess that situation. So then I became a midwife so I could be like, was that necessary?
Yeah.
So now I know.
Okay, cool.
But no, and I think the vast majority, every person I've met wants to have a beautiful birth.
Mhm.
And it is immensely disappointing when they have births that are not what they had hoped or when their bodies do things that they, are really disappointed
Yeah.
by. And those things are out of our control. And we have to accept that there's a certain amount of unpredictability with birth. But I think the cultural conditioning that like birth is this horrific thing or that we should fear it, like I see people having beautiful experiences over and over again where they feel empowered or it's working in these organic ways where it's also speaking to the relationship with their partner or with their other
Mhm.
kids or their mothers and it's immensely healing for a lot of people involved,
Right.
and we have to remember that it's not just one person pushing out a person. It's this whole web of their life and where they come from, and their history, their sexual background, their orientation. All of this informs how they kind of come to it.
Yeah.
And in the hospital, you are beholden to standards that are dictated by the insurance companies. So they really
Mhm.
want to push births through and, get the baby out at all costs. But what we forget is that, and this is very few studies look at this, but the birthing person's experience matters
Mhm.
because they're going to then raise that child. And you're
Yeah.
shaking your head because you're like, yeah, of course, you're a woman. If I have a horrible experience, I'm probably going to feel really bad about it. But that's so rarely included in studies about birth. Is like,
Right.
what did she like her birth?
Yeah.
Did she feel empowered? Did she feel safe? Like,
Yeah.
did she feel like procedures were explained to her, or did they happen to her? Was she coerced into them? Did she have time to, do some research or see was there an alternative or weigh risks, pros and cons? Like, so it's a hot topic because I think we all want this from our experiences, and too often people don't, they kind of get pushed through that experience and they don't know, like they're sitting in the postpartum going like, well, what could have happened, or what if I wasn't induced, or gee, did I have time to kind of like explore other options with that?
Yeah. Okay, that makes sense. I'm curious if you have a more positive outlook on birth centers since it's sort of like midwifery led. I feel like it's kind of an in between option.
So I'm not like home versus I'm not hospital versus home.
Mhm.
It's more, it's the midwifery model of care that I am invested in, which
Yeah.
is which means, and midwives work in the hospital,
Right.
they're, and the places where there's midwifery programs in the hospital here, they are booked solid and it's hard to get in.
Mhm.
Or the policy of the insurance companies are pushing them out, or they're not welcomed in because of there's culture within the hospital system, right? Like there's the OB-GYNs, there's the nurses, and there's the hierarchy.
Mhm.
And then there's midwives, which there's this is a whole probably other podcast about how midwives are trained and how we come about in this
Yeah.
country. But the short end of it is there's midwives that work in the hospital, there's midwives that work at home, and there's midwives that work in birth center. I
Mhm.
choose home because I like being in solo practice. I like to do births there. I like to be an autonomous provider. Midwives that work in the hospital are overseen by OBs, for example, and then their practices are dictated by the insurance companies that are saying, well, no, birth actually can't happen outside of a bed.
Mhm.
Birth can't happen in a pool. Birth can't happen in a shower. Well, guess what? Birth happens in all those places. And the birthing person is moving about and finding which place they feel instinctively safe to be
Mhm.
within reason. We're still monitoring the baby, we're still monitoring them, making sure everybody's vitals are good. So yeah, I love birth centers. I love that there's another option. I mean, they're as safe as home. So it's kind of a funny thing. Either you're in a hospital or you're not.
Yeah.
But birth centers and home, we have the same things, like
Yeah.
all the same medications,
Mhm.
resuscitation equipment, oxygen, all that. But the difference is in the hospital, you're, 2 minutes from the OR versus at home, you're whatever distance you are from the hospital.
Okay, awesome. Well, I'd love to shift into our sort of hormonal health and insemination related questions since that's more so your specialty. And especially, it's really interesting. Congrats that you're trying to have a baby. But I'm curious, yeah, how that kind of plays a role in like now that it's you, like how do you think about, yeah, what you consume even and just your lifestyle? So yeah, if you have thoughts on that before we start.
Yeah. I think that the preconception period is an underspoken about topic, and
Yeah, we've had people say that before, like even things like testing and yeah, just your lifestyle.
testing, preparing your body. I mean, many people take a prenatal and they start there. But as we get older, like I'm 41, and
Mm,
as we get older, our bodies need more nourishment. And how we
mhm,
look and see the health and well being of our bodies is what's the health and well being of our menstrual cycle?
mm,
How's our sleep? How's our
yeah,
elimination? What are our stress levels? Because all of that is going to factor into um, our ability to conceive.
right. Okay, awesome. So yeah, with that, can you sort of explain the connection between hormonal imbalances and any menstrual cycle irregularities?
Yeah. So people don't realize that the symptoms we're having during our menstrual cycles, cramps, breast tenderness, moodiness, night sweats, fatigue, irritability, are not normal.
Mhm.
We've normalized it in our culture that those symptoms are normal. It's just part of being a woman. It's just
Yeah.
part of whatever cycling. And it's a lie. And I, was someone who also kind of believed that. I was like, oh, it just sucks. I have cramps.
Mhm.
I just feel like I want to like claw my partner's eyes out,
Yeah.
like once a month. And I'm like, that's not normal. And so, I started looking at holistically, like, how did I get here? How do people get here? And then we start looking at, well, like, what are the effects of stress on the hormones?
Mhm.
What is a healthy menstrual cycle? Like, we all cycle differently. So,
Yeah.
generally, we're looking at a cycle that comes regularly. We don't have more than 6 days variation. So, a 28-day cycle, not many of us have.
Mhm.
That doesn't mean that that's a perfect cycle. You can be healthy and have a 31, 32-day cycle. How much is normal blood loss? Are clots normal? Clots are not normal. They're signs of hormonal imbalance. My mission is, really to normalize that, like, we are fertile beings well until we're not. We have this like age 35, oh, you fall off a cliff and then you can't conceive. Well, guess what? The vast majority of my clients are older people because
Yeah.
I don't know why. I think because they question the system maybe a little bit more. They're having their second kid. They're kind of
Mhm.
had some experiences. I don't know. Maybe they have a little, we're not, unfortunately, we can't bill directly to insurance. So, there is a barrier to access our care in that sense. Insurance will reimburse, but sorry, I'm all over the place because I
No,
feel
it's okay.
so passionate about this. And
Yeah.
it saddens me. And over again, what I hear at the clinic is people come in and they're like, can you do hormone testing?
Mhm.
And I'm like, oh my God, yes, I can. But there is such a discrepancy on how we test hormones.
Mhm.
You go to an OB-GYN, I've heard the gamut from we can't test hormones. It's not
Yeah.
possible. They change it all throughout the month, which that's not true. To we're only testing them at the end of your menstrual cycle because that's when your hormones are lowest. Well, we need to see the fluctuation in the cycle.
Mhm.
Then what's the difference between like serum testing, blood, versus urine, saliva?
Yeah.
So how are we assessing what's going on in this person's hormones? And there's not a
Mhm.
consensus with this. And I found also that there's not a lot of people that are specializing in healing these disorders either. So what do I do if I have cramps or headaches or cyclical breast tenderness? You go tell your OB that they're probably not going to give you a holistic solution. So what I work with is supplements, diet, herbs to heal those things. So now when I get
Yeah.
my period, it comes and goes, and I maybe have a slight increased desire for carbohydrates, but other than that, no symptoms.
Mm. Okay, interesting. What are the most common causes of infertility related to hormonal factors? And also, I'm curious how you think about sort of healing that even like prior to preconception. Yeah, what should people look out for?
So the most common cause of infertility is not ovulating regularly. So our ovulation is like putting money in the bank. It's
Hmm.
like, when you ovulate, you release progesterone every cycle, and that amount of progesterone feeds into our cumulative progesterone. There's so many different conditions out there now that are impacting fertility, and or people are on hormonal birth control, and to the day they want to conceive, they get off it, not realizing there's a detox period. And
Hmm.
for some people, that detox period can take 2 years,
Yeah.
depending on the length and time they've been on the hormonal birth control. People aren't really informed about the decisions they're making. There's not true informed consent around, I think, some of these things where if people knew that, maybe they would choose different strategies for themselves. And I kind of went off topic, I think, again.
That's
I
okay.
know.
That's okay. Yeah, I think just like
So yeah, how do
relation to infertility.
right, relating to
Yeah.
infertility. um, so so not confirming ovulation regularly is definitely one of them.
Hmm.
And then we go like, okay, well, how do you do that? And so we talk a lot about like if somebody comes to me for like a menstrual wellness visit, which is like I call it holistic gynecology, meaning we're going to look at what are your menstrual symptoms.
Hmm.
Do you have hormonal imbalance? How do we screen for them? Um, and then how do we treat them? So if you go to your OB and you're like, well, I have irregular periods, they're going to recommend hormonal birth control. And that doesn't heal the root of the problem. It just masks it. It's like putting a blanket on a fire. So then when you want to get pregnant, oh, well, look, you never healed that underlying condition. Now we've taken the blanket off,
Mhm.
which was the hormonal birth control, and the fire's still there.
Mhm.
So how do we heal it?
Yeah. So, how does that typically manifest? Like, can someone tell that they're not ovulating regularly without a test? And if not, like, what test would you recommend for someone to be able to tell that they're ovulating regularly, especially since that's the number one cause of infertility?
Absolutely. This is where it gets really exciting because people are really there's all these amazing devices out now. Like technology is booming. The at-home revolution with like I'm monitoring myself or
Mhm.
there's like and people are also looking to like what are alternatives to hormonal birth control? And so
Mhm.
there's people cycle tracking, they're looking at fertility awareness method. And what we talk about a lot is how exactly that. How do you confirm ovulation at home? So there's definitely products you could invest in that are testing the urine metabolites of the hormones that are cool.
Mhm.
That's not, and so like I say to people, you can spend as much as you want or you can spend as little as you want. And there is, fertility awareness method is basically free. You just need to buy a thermometer, for under $10, and then you can
Yeah.
start doing this practice. And then I teach you how to do it. And so we look at, and fertility awareness is it's tracking your cycle on a calendar. It's looking at your cervical mucus, and that's your cervical discharge, which changes throughout your cycle
Mhm.
and is an indicator of ovulation. Tracking your cycle and then taking your temperature, and your basal body temp increases after ovulation. Those three things give you a pretty good picture of what's going on in your body. And our menstrual cycles are four different things. It's the follicular phase to ovulation to luteal. No, wait. Sorry. I'm getting so excited. Um, yeah, you have your follicular phase, ovulation, luteal, and menstruation. And so, how you move through those phases and what the signs are going on in your body, I want people to connect to so that they can feel empowered and being like, I'm in my fertile window. And guess what? If I'm not trying to have a baby, I'm going to use, protection, withdrawal, whatever. Or if I'm trying to achieve pregnancy, this is the time to do it.
Mhm.
So I can, make that happen.
Yeah. So, without testing, are there any signs of infertility that someone should look out for in their menstrual cycle in general? Like if you have an irregular period, does it mean that you're infertile, for instance?
Not necessarily, but it can. And when you skip, if you don't bleed for several months, those are signs of anovulatory cycles, meaning you're
Mhm.
not ovulating. One of the best indicators of your fertility is what's going on in your underwear. So, your cervical mucus was the stuff I was talking about earlier, and it goes through phases where when
Mhm.
you get around ovulation, it's going to get to egg white consistency, these globs that to me are beautiful affirming signs of our health. And I wish we had been taught this when we began cycling so that we would feel more empowered about our bodies. And, a lot of people feel a little disgusted by what's in their
Yeah.
underwear and ew, why is this coming out of me versus no, that's your fertility. That's your strength.
Yeah.
And also then teaching us, well, does it have an odor? Does it have a color? Because those are signs of infection or pH imbalance.
Mhm.
So what's a healthy cervical mucus versus, what could be abnormal? So if you're able to confirm that beautiful egg white stretchy mucus, which is different than arousal fluid, so we talk about when to collect it and how to look at it. I show people pictures and stuff, but all of this is available on the internet too, and there's books and books on it. What I love about fertility awareness is that it can also be an indicator of your health, meaning, hey, like when I started trying to conceive, I was seeing that my temperatures were super low, which was speaking to, my thyroid was technically normal, but I was trending towards an abnormal thyroid. So
Mm.
I'm not going to wait till I'm in the abnormal range and really having a disease state expression. I'm going to try to start, uh, you know, working on how do I get my luteal temps up. How am I going to, meaning, how am I going to support myself in making my own progesterone?
Mhm. So you mentioned more people should know what healthy discharge looks like versus not. So what does healthy discharge look like? Like you mentioned the color and the odor. Like I feel like I've read a lot of I myself have done a lot of like Reddit searching. I feel like that's sort of the typical
Yeah.
route is people just like search on Reddit because
Yeah.
they don't know what else to do.
Yeah, the Reddit, internet, I mean, yeah, we are all out there self-diagnosing.
Yeah.
Practitioners too, we do it too. And I think while I'm doing it, damn it, I know better. I shouldn't be doing this. But
Mhm.
it's like the devil's in the room. We have you have this connection to an
Yeah.
unlimited source of information. A healthy cervical mucus is, you're going to have your menstruum, your period, and then typically you have what are called dry days. So your body has just shed the uterine lining, and then the first half of your cycle is having, not a lot going on.
Mhm.
You're having to build up the follicle, build up the endometrium. So you're going to just see not much in your underwear, or if you're collecting it from your vagina, it'll just be kind of not super present. Then, as your cycle progresses, it starts to get more like sticky, more like the consistency of kind of glue or lotion.
Mm.
And then it eventually moves closer to egg white. So it'll go from like sticky, creamy to like, and all these adjectives are so subjective. So I really recommend people look at pictures. Um, and then from, creamy, it gets to kinda milky to egg white, and then
Mhm.
but for some people, they don't get egg white, like, and we do this, and this is the test of, like,
Mm.
where does the cervical mucus break? So if it's here and it's creamy and gummy, I know I'm not in my fertile window. I could have as much unprotected sex as I want, and I won't get pregnant. And then as it gets stretchier, I know, "Oh, okay, I'm getting in my fertile window. Sperm can live in the body 3 to 5 days. This stuff is designed to keep it around, get me pregnant. So if I'm not trying to get pregnant, I'm going to avoid having unprotected sex during those times." And then once you're getting to here, and it's really looks like egg whites, and it's you can really do this. I know I'm in my most fertile window. I'm about to ovulate, or I have already ovulated, and I know, either have sex now or don't, depending on what I'm wanting. And then after you ovulate, you'll see a temperature increase
Mhm.
with your basal body temp, and there is a method to that. So don't just rely on like a forehead temp. Um, and then you can have as much unprotected sex as you want. You won't get pregnant because you only ovulate once in a cycle.
Mm, okay. Yeah, thinking about like looking at getting pregnant or not wanting to get pregnant. You chatted about hormonal birth control earlier, so I'm curious what are sort of yeah, what is the long-term impact of being on birth control and does it vary? Like I feel like sometimes there are conceptions around like more localized birth control having less negative long-term impacts. So yeah, what are your thoughts there?
Yeah, in midwifery care, it's really about true informed consent. So I want people to understand, what are they taking? How does that impact them? And it's not so much about like, well, what does Christian do? Or but I do want people to know that I do have one strong bias, and it is really against hormonal birth control because of
Mm,
how it depletes the body and
mm,
what it's doing to our hormones. So you can look at cultures, indigenous cultures that don't go on hormonal birth control, and they don't even have menopausal symptoms.
mm,
And you go, why is it that like people are having horrific menopauses? I haven't gone through menopause, but it doesn't seem fun from what I've seen and or what my patients explain. And I'm like, why? And the more research I've done is because like we're messing with our hormones, and one of the benefits of ovulating every month is that you're putting that progesterone, you're releasing progesterone, you're making progesterone, releasing it, and then you're essentially putting it in a bank. And when you're on hormonal birth control, you're on synthetic hormones that are they're named similarly, progestins, which are not
yeah.
progesterone. But people go, I've been on a progesterone only birth control. And I'm like,
Mhm.
that is not true. You're on a chemical that your body's going to have to detox, and you're not getting the same bio support from it. So, meaning when you ovulate every month, it's going towards your mood health, your bone health, your cardiovascular health. Huge reasons to ovulate every month. And so, when you suppress ovulation with a hormonal birth control, then the next medication that women are more likely to most likely to put on are antidepressants
Mhm.
because it suppresses our moods. So now we have all these people who are not getting the benefits of the biological cycle of making and storing their own progesterone, and now they're depressed.
Mm. Yeah, so you chatted about up to 2 years of sort of re-regulating following birth control,
It can be
so
up to 2, but not every some people can, ovulate a month after. It
yeah.
depends on what was going on with them before prior. I see people that have PCOS, they were put on birth control for 10 years or the NuvaRing or the Nexplanon, the implant, and
Mhm.
then seems like people who have hormonal imbalances to begin with have a harder time detoxing it and then, take longer to conceive. But we
Yeah.
work on, well, how do you detox hormonal birth control, right? How do we support your body? Because it's not, look, we're given the information and we made the decisions that we did at the time. Like,
Mhm.
you know, and so it's not about shaming anyone who's on it. It's just like, do you understand the implications? And if you do you want to continue being on it?
Mhm. As a midwife specializing in hormonal health, what birth control options do you recommend if you're not so much a fan of hormonal options?
Yeah, if you're like, look, I don't want to be monitoring my cervical mucus and doing my basal body temp, is fair. There was definitely times in my life which I was like not as body literate or
Mm.
just didn't have the time or I was running and I didn't care. So an IUD, a non-hormonal IUD is a great option for some. Some people do get some pretty negative side effects, which would be like heavy menstrual periods or
Mhm.
discomfort during sex. So, but for the vast majority of folks, they, once they have their IUD put in, don't complain. And you're still cycling. So you're still getting the benefits of making your own endogenous progesterone. And so you're not messing with any of your biological balances.
Yeah. Okay. Interesting. Yeah, I recently got on the Nuva ring.
Mhm.
So I chose it because I kind of scared of the IUD.
Yeah.
Because I've had so many of my friends like talk about, yeah, just like the negative side effects that have come with it. Like pretty much all of my friends have had some kind of really, really bad effect with every form of birth control. Yeah.
It's an imperfect, yeah. We've been trying as a society to come up with a solution that works because, we do need to have the right to be able to determine when we want to have babies and when we don't.
Mhm. Yeah, definitely. I'm curious how you think nutrition and exercise play a role in hormonal health and what typical lifestyle changes you recommend, especially if someone is trying to conceive.
Huge. Yeah. So, well, one of the first things we say is like, if you're trying to conceive, to act like you're pregnant, essentially. So, like, is this the level of stress you'd want to be running under if you were
Mm,
pregnant? Is this how you would eat? Because we do all kind of like be like, well, I'll do it when it really matters.
yeah.
But like I said, I work with older folks trying to conceive and myself included. And what I see is that it's super, super important is to start eating the right amount of protein for our bodies. Like that's
Hmm.
a super simple thing. As women, I think a lot of us have either histories of eating disorders or what I'd call just disordered eating, where we're
Mm,
kind of like conditioned to be cautious about food and weight. And so then what I see is people skipping meals or doing intermittent fasting when, you know, I would rather see people doing things like timed eating so that their body's still getting regular nourishment because that is what our hormones need. And then moderating stress. So, stress, the same hormones that build our sex hormones also help us mitigate stress, make stress hormones, or the hormones that help us mitigate stress. So, what people don't realize, and it's called the pregnenolone steal. So when your body's like, oh, we're gonna ovulate, but actually, oh no, I'm dealing with like a death and a breakup and
hmm.
I don't know, this person's whoever this person is. I know you're out there, but this is a tough moment. Your body's gonna prioritize the stress over
Yeah.
reproduction.
Mm,
So then and you do that times maybe 10 years, and then you go, now I want to have a baby, but actually I've never changed this pathway in myself or nourished it. We're gonna have to nourish it and it'll take time.
yeah. Okay. So, are there any foods in particular that you recommend if someone is trying to conceive? Like, I know you mentioned more protein. I feel like I
Yeah.
read eggs a lot should
Yeah.
be like in high quantity.
Honestly, I mean, if I could get everyone eating the organ meats, which
Mm.
everyone's like, "Ugh, it's hard to get people to be like, yeah, liver and marrow, the things that build life. And they're the most nutrient dense. So, one of the reasons I work with supplements is like it's a huge industry, right? So we have to be careful about like who's selling us what and why and where, how is that supplement sourced and made? And, it's unregulated, so it's really hard for us to know what we're getting. But what I tell people is our farming practices are not as nutritious as they used to be, nor with our animal raising
Mm.
practices. So we have animals that are not eating natural diets. They're eating, things to bulk them up, but not necessarily nutrient rich things. So all of our food chain is more or less depleted. Even if you're eating organic, you're just like our soils are depleted. And so what I say to folks is like I want to recommend supplements supplementally. So meaning like where are the deficiencies? And then let's build you back up in those places. And then once you're at there, you can cut out the supplements. So it's not just like indefinitely or people are like that's a big question I get or people are like when do I stop taking the supplement? And you're like
Mm.
when you have no more symptoms.
Yeah.
And then we know you're nourished, and or if you're having adverse symptoms, then we're going to have you stop taking the supplement. So focusing on protein. And what I recommend is really like 75 grams, which is a lot. It's
Mm.
like 25 grams of protein with every meal. And then when you'll
Yeah.
find is if you just start with that, it's going to then speak to your energy levels, your sugar cravings. Just that little adjustment will really help support your body so that you don't start spinning out or like relying on the other things that have compensated for the lack of nutrition, like the refined carbohydrates, the sugar, the caffeine. Not that you can't have those things while you're trying or when you're pregnant, but we want to look at like, well, why are you craving them? So one of the
Mhm.
things we see is like when folks crave something sweet after every meal, it's that they didn't get enough protein in that meal. So the body's like, sugar is readily available
Mm.
um, eh, energy. Like I'm going to demand that, my gut is going to be like, you need to give me that
Yeah.
because I didn't get enough of what I needed. And then one of the things that protein does is it balances your blood glucose. And so the relationship of insulin to hormones is a whole thing that I could go off on. But just the simple end of it is that protein helps balance and stabilize the blood glucose so that, you don't have those spikes so that your body then does maintain the hormonal balance.
Mhm. Okay.
But it doesn't mean like you have to go paleo, for example.
Yeah.
It could be plant sources too.
Yeah.
Definitely you can do this as a vegetarian.
Okay, awesome. I feel like hormonal health is honestly often ignored. Like it just seems like a more neglected area of health. So I'm curious how you think more healthcare providers can be better about sort of addressing hormonal health in general. Yeah, especially like thinking about fertility and folks that are trying to conceive.
Yeah, hormonal health it's an under, in med school it's not really taught. How do you heal hormones? It's not
Hmm.
taught at all. And that's why, it's not that your OB doesn't want to help you. It's that they're not taught and then the tools that they're given are things like hormonal birth control, which we know don't heal the symptoms. So what I'm invested in is people understanding what their fertility looks like, how to monitor the well being of their body by their menstrual cycle, and then how do you eat to support your hormones. So, we are a culture of convenience. We definitely like our, our pills. But I want it to be seen more like this, where like your lifestyle and diet are your foundation. Your supplements and herbs are things that you can do to nourish those things. But if you're just trying to throw a supplement and you're like, I'm gonna still work, 50 hours a week and be super stressed out and like eat on the run, never cook, it's going to be really hard to balance your hormones. We're a holistic human. And as much as, I've also been guilty of like, I'm just kind of throwing a supplement and not really wanting to change my life. It's like we really we have to,
Yeah.
you know?
Yeah. If someone is experiencing fertility challenges, where should they start and what kind of like treatments or solutions would you recommend?
So, I mean, fertility is like, wow, this whole topic, right?
I think I forget if this was it exactly, but I'm pretty sure we had a guest on that basically said that the greatest cause of fertility challenges is unknown.
Yeah, it is.
And yeah, I think she was a IVF doctor.
Yeah.
But yeah, it's just wild. So yeah, where should people start if they're having trouble conceiving? And also I'm curious, like how long should someone conceive naturally
Yeah.
before they start seeking out these kind of treatments?
That's what
Or should
I
they start before?
absolutely. Like we should know what's normal. How long is trying normal? So how infertility is diagnosed is trying for up to a year unsuccessfully.
Mhm.
Okay. What I want to know, and then if you get older over the age of 40, it's trying for 6 months. I want to know what is the health and well being of their menstrual cycle, right? So, like that IVF doctor, and many IVF doctors say this, we don't know why is this person not conceiving. They're not doing studies on what is the health and well-being of that person's menstrual cycle before they go to those interventions. So that is the number one is like, people will try and then they're like, oh no, well, then let me rely on this technology, which is a fine solution. Um, but it's not an option for a lot of people. It's financially inaccessible. So it's not, without its barriers. The other thing to start is like, are they tracking appropriately? Do they know are they just kind of like, we're just kind of doing it at our own rhythm? Or are you like taking your temps and doing LH strips? And, there's like, are you wearing one of those
Yeah, or
rings?
a ring.
Yeah. So
Yeah.
that's the temp ring. And
Yeah.
that's like, if you don't want to do the under the tongue, I think those are great.
Yeah, yeah, I
Um,
track it for my sleep. I actually didn't know when I got it that they had menstrual cycle tracking, and I think they actually launched it because I got it over a year ago, but, they launched it while I had it. So, yeah, I just got it to gamify my sleep basically and,
yeah.
better improve it, but, yeah, it's been really interesting because even yeah, looking at the body temperature, I was better able to predict when my period would come, and even just the fact that it tracks body temperature, like, sometimes I could tell if I was about to get a cold because my body temperature would be slightly higher than normal.
Right.
So,
Right.
yeah, that was all interesting.
Yeah, or drinking.
Yeah.
Definitely
Yeah.
shows that too. Yeah, so there's these devices and things that you can introduce to be like, okay, are we trying in the right window? Are we trying at the right time? We look at the partner too or the donor. What's the quality of the sperm? What's going on
Mhm.
there? What are your expectations around conception? So like, most people want it to not be processed, but can we normalize that it can take time, and that is part of the discussion and decision making with choosing to do other interventions, but then also knowing that the interventions don't necessarily speed up the process for some people. So it doesn't at all. So then I go back to we have to then prepare the bodies for these processes. So, like looking at the menstrual cycle, are there deficiencies? Are they confirming ovulation every month? And then, what are the lifestyle and well being of the partner, the sperm? So, like, or the donor, and then how can we support them to also then have healthy bodies?
Yeah. Thinking about sort of partner support, how can partners best support one another through times of infertility?
It is a very challenging topic. And I think there's also like not a lot of spaces that are going to address the psychological, emotional, the spiritual, and the physical of going through infertility. And one of the reasons I became licensed as a craniosacral or certified as a craniosacral practitioner, in addition to a midwife, is that I felt like I had a lot of tools for my patients or clients, and it would be like we were these two brains sitting in the room talking, going back and forth, looking at labs and numbers and values and times and, all this. And then I was like, I'm missing a piece to healthcare, which is addressing the physical body, like the energy body, the psychological body. And so craniosacral therapy is a way that, we can work with stored histories or traumas in the body and help people clear them. So it might be that, like, this person had a miscarriage or an abortion that they haven't processed through, and
Mhm.
that's still kind of occupying their womb space.
Mhm.
So we can get, I my brain is kind of both worlds where I love the science stuff and I love, lab work and all this. It's amazing all the stuff we can do, right? Like, and then there's also the metaphysical that we can't deny. And so it's working on the soul realm.
Well, I'd love to chat about insemination as well, because I feel like typically people, I think when they think about fertility, they think women, and yeah, but I feel like often male fertility is sort of an ignored section of fertility in general. So yeah, in the context of intrauterine insemination, aka IUI, what is the process, and yeah, how do you define success for an IUI?
hmm Yeah. So not all midwives offer IUIs. It's something that I decided to do additional training to be able to offer.
Can you do it at home?
I can. I prefer to do it at my office because I do need like my microscope and stuff. But
Yeah.
I do offer home visits, but it's a little bit easier just at my clinic.
Yeah.
But our clinic space it's really beautiful. It's like it feels more like a spa than a clinic, and you know our paps and inseminations are done on like a massage table with like a soft wool cover, and we don't use stirrups, things like that. And it's also with a provider that's, not a hyper medicalized space. So kind of
Mhm.
once you go into that, the fertility clinic realm, it becomes really about timing and scheduling and ultrasounds and this whole experience that really makes people stressed out.
Yeah.
And as we know, stress really impacts fertility. So I started offering IUIs for two reasons: to support those who wanted to conceive babies or were having issues, but then also to work with queer couples because I love holding a safe space for non binary and queer folks. And the birth world, reproductive world is mostly dominated by hetero, monogamous couples, and well, that's just not a good reflection of all families. So yeah.
Okay, awesome. Do you typically recommend trying IUI prior to trying IVF? Or what is sort of the
Yeah, we
relationship?
do. Yeah. I mean, it depends. So, okay, we do in a sense of if it's unexplained infertility. If it has to do with like egg quality, then we're going to be speaking more to IVF. But if
Mm,
it's like motility on the sperm, then an IUI is a great solution. Or like I've had queer couples try ICIs at home with donor sperm, but they're using often frozen sperm, which is not, it doesn't live as long once thawed. So
mm.
I do recommend an IUI with frozen sperm because it does get it that much closer to the fallopian tube, to the egg. So
What is an ICI?
intracervical, meaning
Okay.
like it's penis and vagina sex,
Oh,
essentially.
okay,
Yeah.
okay. Okay. Cool.
Intrauterine is going past the cervix into the uterus.
Yeah, so
Yeah.
typically with like an insemination tool.
That's what we do. Yeah, ICIs, I just tell people to do them on their own, and I'm like, here's how you cycle track. Here's how you, confirm ovulation after the fact. Here's signs of looking. Often people just do them too soon at
Mhm.
home. They see their LH surge and then they just want to go. But we talk about how to use your cervical mucus as indicators of fertility and timing. And so, because we're not all 24-hour ovulars, we're not all the same people.
Yeah.
So we're complex beings. So how do you read your own body signals?
Mhm. Okay. Um, so what are the most common misconceptions around IUI and also with that IVF and maybe even ICI?
I'd say with ICI, it's the timing thing. IUI, frozen versus fresh versus washed sperm. So, like, when you work with a Cairo bank, you're getting often frozen washed sperm, or it can be frozen and unwashed. And we'll wash it, meaning we'll separate the sperm from the seminal fluid in the clinic. I look at it under a microscope to see how it processed, and then we'll do the insemination right there. Or people will be working with like a known donor that, so they'll have fresh sperm, but fresh sperm has to be washed before you put it into the uterus. So we'll do that as well there. With IVF, I think some of the misconceptions are I'd really recommend people to heal their bodies before they go through those processes to increase the likelihood of it working.
Mhm.
Meaning, take 6 months to really like, you know, feed the mitochondria of your cells, make sure your menstrual cycles, you're growing a nice thick endometrium that's thick enough to support implantation, to increase your chances. And I think with fertility clinics, they're responding to the need, and they're not really, I'm not here to sell people on something. I want people to have good care and to have information. And so I want I guess I do wanna sell them the sense of, like, I want you to take care of yourself before you go through these things, because it's immensely emotional to go through IVF, and it's incredibly expensive. A lot of people don't have enough, money to go through multiple cycles of it.
Yeah.
So, without going into, or, you can get loans and stuff, but without going into immense debt. The other thing is that we're seeing higher rates of pregnancy complications with IVF pregnancies, and I think that that's something that's not in the conversation around IVF. And it's not that this is such an emotional, primal thing. Like when people want a baby and they're not getting one, it's so primal and it's so
Mhm.
heartbreaking. And we're so lucky to have a technology that will help us. But again, in the information, we need to also let them know that they have higher incidences of pregnancy complications. So, and if they're okay to accept this increased risk, then they should go ahead for it. But if they're not, then or they should be informed about what those things are, meaning increased risk of hypertension, of developing preeclampsia, abnormal placental adherence, needing to be induced, things like this. So it's not just getting you pregnant. We want you to get pregnant and have a healthy pregnancy and a beautiful birth.
Yeah. Okay, that's awesome. So you chatted about making sure you wanted to have an inclusive space for queer families and sort of non-traditional family structures. So what tips would you have for families who are queer families or have non-traditional family structures if they're trying to conceive? I feel like a commonly asked question, I remember searching sort of like queer family conception, and one of the common questions was like, what is the cheapest way for a queer family to conceive? So I'd also love to get your take on that.
Yeah, because you're immediately put into,
Like
often.
surrogacy or and it's so expensive.
Yeah, or, even if you have a donor that's a friend or maybe gonna be a co-parent or a special parent, like a different type of dynamic, there's screening fees. We recommend they have like STI screening, and that there are either if it's a couple, that there is second parent adoption of that child to the non-gestating parent, just so that things don't get messy and that there
Mhm.
is a clear understanding amongst people. A lot of fertility centers are not centering the queer experience. And so, I work with folks that are non-binary, that or trans, that want to carry and gestate a baby. And, how do we make these spaces not feel violent for them, or non-affirming to who they are?
Mhm.
And it really just takes a little awareness of a provider to adjust their language, their intake forms, and to acknowledge that this is a couple who are coming together, or or a solo. I've worked with solo parents by choice, that have are having to come against more obstacles from their society, and I don't want to be one more thing in the room that's going to then feel like, making them at all feel estranged from this beautiful experience, or
Mhm.
what it could be a beautiful experience.
Yeah.
So.
So what would be the cheapest option
Right,
for
money.
queer
So
families?
the cheapest option is, honestly, doing the ICIs at home.
Mm.
So getting frozen, well, how you get your donor is really personal. But if you're buying sperm to do an ICI at home, whether or not you don't need to invest in there's like a special syringe. I'm not gonna like shame this company, but they're selling a special syringe that I think is overpriced. It's an overpriced syringe with good marketing. And maybe if you were gonna spend the money somewhere to, talk to a midwife around, or take a fertility awareness clinic or class, so you're understanding your cycle, so that, and tracking it for several months before you start trying, so you can, really hone in on the timing, because frozen sperm doesn't live as long outside the once it's thawed. And then, midwives are a great option for IUIs. Like, I'm a third of the cost, a third, almost, yeah, a fourth or a third of cost of working with a fertility clinic.
Mm.
The reason being is that I'm not paying a huge staff. I'm, in a partnership, and yeah, I just wanted to make it accessible, and because money is a part of the stress, right? So if you're going to try to normalize, hey, you might need 5 IUIs, and that's
Yeah.
okay and normal, you know, this will make it more accessible.
How is an ICI done in at home, basically?
Yeah, so if they have frozen sperm, they're gonna thaw it. It comes in a big tank. There's instructions on how to thaw it in the tank. And then if they've done careful cycle tracking and charting, so they're really good on their timing, because not everybody ovulates 24 hours after an LH surge, and that is like such a misconception. And then, or some people do it 12 hours, and they don't realize like you're working with sperm that's less. It's been frozen and it's been washed, so it's like it really has a reduced viability outside the body, so we really got to hone in on the timing. So, and then how you do that is with tracking your fertile signs. So some people ovulate like 36 hours. Some people even ovulate up to 72 hours. And it's not the same every month for
Mhm.
everybody. So like we are sensitive beings where if like we experience an MS stressor and I've had my LH surge, my body's going to be like, "Oh, poor time to release an egg. Let me delay as long as I can." And then, and that length of delay has to do with my own nervous system. At home, if you're doing this, you've timed it right, you've thawed your sperm, and then what people will do is draw it up with a syringe, and then essentially you just put it into the vagina. And we recommend having an orgasm after because we know the contractions of the uterus when you have an orgasm help move the sperm up closer to the fallopian tube.
Hmm. Okay, interesting. If someone is looking for a sperm donor, what would be your tips there?
Yeah, like we start with, is it known versus unknown?
Mhm.
Do you have a friend or somebody in your community that you think would be open to this? Navigating second parent adoption. So we give people resources for lawyers, to really be clear with these boundaries so that, do you want that person to have parental rights? Because they will,
Hmm.
unless they revoke them. Do you have a partner in which you want to adopt the child? So they are also seen in the eyes of the law to be the parent. So there is some navigating depending on how you're coming to it. Yeah.
Yeah. Okay, interesting. Yeah, I know you mentioned sort of legal considerations. What legal considerations should someone be aware of if they're looking at having a sperm donor or even an egg donor as well?
Yeah, because we've even had surrogates too. People will pay surrogates to gestate their baby. So legal considerations would be like working with those lawyers to make sure that there's a clear understanding of like, is that person going to hold parental rights or are they revoking it? And then also, who else do you want to be a parent of this child
Yeah.
legally?
Have you ever had I guess like I'm curious what's the most complex family structure you've been a part of, if you're allowed to speak on it.
I am. Yeah. I mean, it's always anonymous the way we share information. I've had, I'd say in this evolving world of different relationships is like, I definitely have folks that are like in poly relationships with co-parents, and it's really quite beautiful to see how people have forged and navigated relationships and dynamics with boundaries and a lot of good communication, clear communication setting and roles and things like that. I had a couple that had two assigned female at birth folks, with one, he identified as a he, um, and so they were like a triad. Yeah.
Okay, interesting. How did they
And one
choose?
gestated the
Okay,
baby, and the
the
other
other
one
two
was
were
like a
donors.
yeah, the cis male partner was the father of the baby, of the gestate he impregnated the person who gestated, and then their their third, was also a co-parent.
Oh, okay,
Yeah.
interesting. Um, in terms of post-conception support, what are sort of considerations for queer families, and also what are the best resources for queer families if they're looking at IUI and insemination?
Yeah. Resources, I'd say try to find a queer friendly provider. I'm queer myself, so I think that that also helps kind of just puts families, people at ease, that they're not, that their relationships will be seen as valid and
Hmm.
important. And I can't tell you how many times I've seen providers, misgendering all over the place, but then also like seeing, this person's wife as their sister or their mother, and you're like, geez, it just takes one question of sensitivity. It's like, how are you guys related?
Yeah.
How do you know each other? It's
Yeah.
like not that hard.
I'm curious, what is your term, like go-to term for someone who is pregnant? Because I tend to say birthing person, but
Yeah,
I
I've been saying that
honestly,
too. I know.
yeah, I get a lot of social media hate when I say that.
Oh, really?
Yeah, well, I think
What are people saying?
they're just like, "You're taking away my femininity
Oh,
as a
yeah.
woman," and, yeah, it's actually mostly from women that, like, feel so charged about it.
It's true. Yeah, this is a thing that's happening now. I just ask people what they want to be called.
Okay, yeah.
I when I'm on podcasts or if I'm the languaging on our website is, we say breast breast / chest feeding.
Mm,
I do use birthing person or I just say the pregnant person.
yeah.
Um,
I say that too, and people are like, "Yeah, I get hate for it."
I'm maybe getting hate, but they're not, I don't know, telling me. I don't know.
Mm.
And I'm sorry because we do obviously celebrate women and, those who identify as women. But we also have to think like, as medical providers, I really think we have to try to be as neutral as possible. And birthing person
Right.
is a way of including everybody, where like saying women, doesn't include my trans clients and and is actually really harmful for them.
Mhm. Yeah.
And there's, I mean, talk about like people who are like under screened and under get supported services in the medical field is like, people who are just don't feel safe going to those spaces. So
Right.
we all need space to go to be like, talk about our bodies that feels okay, you
Yeah.
know?
Yeah, we did, an Instagram live with, a trans, non-binary person recently, and yeah, and he was mentioning that, yeah, he goes by he, they, but, yeah, he was mentioning that he basically brought a packet of frequently asked questions to every single appointment he had surrounding his birth and pregnancy. And yeah, I thought that that was really insightful because I feel like even pregnant parents who are like completely traditional, like cis parents in like a marriage, like even they could benefit from having like FAQs just about their own medical history or what have you. So yeah, I thought that was something like really notable to just learn from.
Totally. And I'm seeing more of a trend in with our clients too, where people are like, we're going to try not to like overgender this child and just, let them reveal to us. And, it brings up so much in society and people get very visceral reactions. And I guess I just keep going back to like, well, I mean, what if it was you who didn't feel like you were being represented or like affirmed to who you were? Like
Mhm.
you'd want this. So like it's like not, and so I think part of this is like around like how are you centering the discussion in your head or with your friends or to people you're commenting on Instagram or whatever. Like, is this person talking about you or
Yeah.
are they like just trying to include people?
Mhm.
So are you centering yourself in a conversation that's really not
Yeah.
about you in this
Yeah.
moment?
Yeah, that's kind of what I always thought was interesting about the whole pregnant person or birthing parent terminology discussion was like I feel like if I'm talking to a mom that is like female identifying, then I can call her like a pregnant mom.
Totally.
But then
But
it
not all people
doesn't.
want to be moms. I mean, I've
Yeah.
had, you know, um, gender nonconforming parents that were like, I'm not the mom, like, and they had a cute name that they wanted to be called by the child. Like, and I was like, what's the kid going to call you? And they were, and they had
Yeah.
come up with
Like
something.
Kris Jenner, I think her grandkids call her Lovey.
Exactly. Exactly.
Yeah.
Not hard. And what does it do for that person? The world.
Mhm.
So why would we not want everyone to have that
Yeah,
affirming world?
definitely. Okay, cool. Well, yeah, thank you so much for being here. I really appreciate it. It was interesting because we haven't had, yeah, anyone chat about hormonal health yet on our podcast. So, yeah, I'm really grateful that you're here today.
Cool. Thanks for having me.
Yeah.